All right, gang, picking up where we left off. This is a 12 lead EKG. Important things about the layout. We'll start here at the very bottom of it. This is the 2 lead, and it is the same. It is running the entire length of the strip. So this is just one long recording. The strip itself is divided up into 3-second sections. You'll notice these vertical dotted lines that are placed here. This one right here, and this one right here. Each of these represents a 3-second segment. So this is 3 seconds. Of course, this is 0 at the start. And then this will be 6, this will be 9, and then of course at the end we're up to 12 seconds total. So a 12 lead EKG is 12 seconds long with a nice long reading at the bottom. These upper parts, however, are notably different. 12 leads are divided up into vertical sections so that you'll see how lead 1, 2, and 3 are all in the same column. AVR, AVL, AVF are in their own column. So on goes with, there are V leads with V1 through V3 and then 4 through 6. What's important about this, these first 6, 1, 2, 3, AVR, AVL, AVF, these are the limb leads. Whereas all of the V leads together are the pectoral or chest leads. Within these vertical columns, it's important to note that you can only compare vertical columns with themselves. What I mean by that is, let's take this third beat right here. This third beat is the exact same heartbeat looked at through all 3 of these leads. If I wanted to focus on, let's say 1, 2, 3, this third beat right here, this is not the same as this one. You can't compare one column to the next column, and vice versa. If I had a PVC right here, that PVC would show up on this one, and this one, but you wouldn't see a PVC anywhere else along your strip. The real big value of putting this all together is that in a 12-second period, assuming you get a nice clean 12 lead, you are looking at one continuous heart rhythm along the bottom, and then with that layering all of these different vectors, all of these different angles at which you look at the heart to come up with a nice overall picture. So that's the basics of a 12 lead itself. Because not many people focus on it in regular basic arrhythmia, we're going to talk about the V leads or the pectoral leads. So these pectoral leads are pretty awesome. There's a couple reasons why. The main part is it focuses on the ventricles really well, and so it tells us a lot about their function. The point I want to make on this slide is R wave progression. If you look at V1, you'll see that the R wave is small. But as you walk through, you'll see how that R wave changes so that by V6 you have a tall R wave. By contrast, if you'll look at the S wave, you'll notice how it does get a little larger and then begins to creep off to the point where there's almost no S wave at all. This is what we talk about in terms of normal R wave progression. And again, to point out, each one of these beats that we're looking at is the exact same heartbeat from 6 different angles, 6 different vectors. And that makes sense. If I look at the heart, measure the amount of the electricity that's flowing from this V1, which is right there in the anterior of the heart, maybe focusing more to the right side of the heart, I am not going to see the same electrical flow from that side, the right side of the heart, as I am from this left lateral lead, which is the V6. And that makes sense. What's really cool is the V3, which sits right about in the middle, and this one should be isoelectric in a normal person. And what I mean by that is that your R wave and your S wave are almost identical in terms of height because it's right in the middle, so it's not more or less of the others. That's basic R wave progression and what we're looking for in a healthy EKG. If the patient has any sort of problems with their ventricles, either the amount of muscle mass they have due to hypertrophy or scar tissue due to an MI, that can throw any number of these things off. Vectors. I've started mentioning it, and here we'll talk about it with a little bit more depth. Vectors are a representation of the electricity flowing through the heart. The idea is this: each cardiac cell has its own electrical flow, has its own focus. And so think about a crowd of people standing in a room. No seating, they're standing. They're going to be looking at each other. There's going to be different groups. No one's really focused in one direction, or not everyone's focused in the same direction at once. Maybe all of them are looking sort of towards the front of the stage, but maybe not always. That's essentially how the heart behaves. As electricity is discharged in the heart, each one of these cells winds up focusing a different direction. And depending on what angle you're looking at the heart from, you may see a different amount of electricity. Overall, the mean QRS, the mean vector of the heart, is determined by muscle mass and where the most electricity is at during that given moment. Looking at the heart itself, it makes a lot of sense that the left ventricle, which is the largest, most muscular, most massive part of the heart, is the one that's going to be creating the most pull in terms of a vector. So your normal patient should have a general vector in this direction towards that large left ventricle in general. We'll go into more of that later. Leads. This next section's a little detailed, but I'm going to try and keep it as brief as possible. We're going to focus on what the leads represent, not how to put the stickers on. What I want you to realize is how the layout of these leads, not just our typical chest leads, or not our typical limb leads, but adding those with the chest can help create a really great three-dimensional picture of the heart with a nice single test. So, basic reminder, electricity flows from negative to positive, so that we are measuring everything from the positive end. The positive end is where we're looking at the heart from. And other part I will mention is unipolar leads, which is going to be your AVL, AVR, AVF. Those are unique ones that are created through an algorithm that the monitor can do. And so it essentially creates a assumed lead in the center of the heart and measures things from an opposite direction. And I'll show you some more of that here in a little bit. This is our end point. This is where I want you guys to get by the end of today. by the end of these lectures is understanding how this works. But the overall idea is this. We have a heart, we have multiple little vectors all pointing sorts of different directions, but the overall average mean vector is in this direction. So in general, most of the electricity in the heart, normal heart, is flowing that direction. When you take the leads, the AVR, AVL, AVF 2 and 3, and 1, and realize that each of those leads is acting like a camera looking at the heart from a different angle, the sum total, or the average, of each of those individual items and what they see comes out to this, so that we can use the information collected from each of these leads to determine how electricity is flowing through the heart. This is the endpoint. We'll get you there. First off, this is a more traditional layout. You may have seen this triangle shape before. Basically what it represents is you've got your right arm, and left leg. They're assuming a 3-lead system. With that information, you can say negative here, positive here. That's good old-fashioned lead 2. Positive down here, negative up here. That's lead 3. And there's lead 1 with a negative and a positive. What's really cool is going from the center here, going straight down, you have AVF, which says it's positive down here, and assuming the central node is negative. Your AVR and your AVL function in the same way and are measuring out in these directions. Those have all been stacked up into the tightest, smallest representation. Now, everything we've been talking about so far has been frontal plane, and that's the limb leads. We've also talked about the horizontal plane, which is your pectoral, or your chest leads. And I just like this representation really well because it, in the most simple way possible, says, here's the difference. The frontal plane is looking from these vertical and directions, from the sides, straight up, straight down. Whereas a horizontal plane is looking through the chest from the front to the back. Standard limbs, again, just to reinforce, negative up here, positive down here. Positive, negative, positive. Okay, lead 1, 2, 3. Adding that on top of this, which is going to be your augmented leads, so your AVR for right, AVL for left, AVF for foot. You will then notice, I'm going to switch back and forth between these two, how within that same triangle they all look different directions. We can then take that, pull it out further, and say, how would the same heartbeat look from all of these different leads or vectors? Because that's all these leads really are. They're measuring the vector from their particular angle on the heart. And what we start noticing is a pattern develop, that leads that are in looking at the heart from the same area create EKG rhythms that are very similar. So let's focus on our lower leads here. So let's look at lead 2 and lead 3, and you'll notice they both have the same spot at the bottom of the heart. They're just looking at it from slightly different angles, and you'll notice that those two look pretty darn similar. What's really fun is on the next slide, our AVF is also looking at the heart from the bottom, which is right in the same neighborhood as 2 and 3. And so I'm going to switch back to the other, and if you look at things like your P-wave QRS, they're not all that dissimilar. Now, to really point out a contrast, think about your 2 lead right here. And we're going to look at your, so there's your 2 lead. We're going to look at your AVR, which is flowing almost, if your 2 lead is going this way, your AVR is essentially heading the opposite direction. And it really is. Look at this. Inverted P wave, inverted T wave. It's the exact opposite of a 2. And it's for that reason that we don't really use the AVR all that often. I'm going to head way back here to this, and I'm going to point out this final part for now. And it's that the AVR really is a bit of a black sheep. This is the only lead where your P waves will be inverted. And that's normal. Every other lead you should have upright P waves in. The same thing goes for the T waves. Your T waves should be upright, all leads. Moreover, they should also follow your QRS. So if your QRS is going upright, so should your T wave. If your QRS happens to be inverted and being more downward, it should be the same way. All right. So stacking all of this together, you wind up with the hexaxial system, which is just a really fun way. Hex meaning 6, and of course axis being an axis. And so what we do is we shift the center point and say, if we're going to put all of these together, is there a way we could say there's a center point from which they're all pulling this or measuring this information? And that's what this winds up being. Assuming that each of these leads is coming from a common point of origin, you can add them all up, where your lead 1 still goes to the right, your AVF still goes straight down, 2 has a bit of an angle, 3 is the alternative angle to that, your AVR is almost opposite of your 2 lead. Putting all of these together creates this. With this information that we're going to use together, we're going to calculate the mean QRS. And that's going to be extremely helpful later on in determining the overall vector of the heart. Because if there's something wrong, your vector won't be where it's supposed to be. Last bit, your horizontal plane leads are looking at the heart from front to back, looking through the chest. This picture doesn't represent it as well as this one does. This slide here just walks through and reminds you of where all of the stickers should be placed. I'm not going to belabor that all that much. I will mention, though, that I forgot my L here and my L here for sternal. But please keep these in mind. What really matters is this photo. And this demonstrates exactly what sections of the heart this is looking at. Now, of course, this is your right side, this is your left side, this is your left ventricle, and this is your right ventricle in here. And what we can wind up doing is grouping these together. And we kind of pair all of these off, and we will say that lead one, V1 and V2 represent the right ventricle, but not so much of that as the septum itself of the heart. Trust me on this when I say it, keep that in mind for later on. V3 and V4 represent the anterior of the heart. Now, remember earlier when we were talking about the LAD, left anterior descending artery. V3 and V4 look at that front half of the heart right here, where the LAD walks past. So if there is problems with the LAD, there's going to be problems with the heart. V3 and V4 are going to do a great job of looking at the heart from the correct angle to pick up on that. Finally, you have your V6 and your V5, who are way out here on the lateral side. And of course, the lateral side is going to be your left circumflex artery. So V6, V5 are looking at this far left half of the heart. And now you can see just V1 through V6, each of those has their own designated areas. Now, sure, is there overlap between V2 and V3? A little bit. And that's where we come to this. I hinted at it earlier, and now's the time to really put it together and realize what all this is saying. 2, 3, and AVF look at the heart directly from the base and the most inferior portion of the heart. So if I have that occlusion in my right coronary artery, that right coronary artery is going to be disrupting flow to the inferior portion of the heart. And so if I'm having trouble there, these are the leads that it's going to show up in first and be most obvious. If I have problems with blood flow to the lateral portion of my heart, or maybe I just have hypertrophy, it could be something like that too. Any kind of electrical disturbances on that portion of the heart from a lateral aspect. Who measures the lateral side of the heart? Well, 1 and AVL, as well as V5 and V6. So you've got AVL way up here in the upper right is where it's looking at. You've got 1 that's looking from the shoulder. You've got 6, V6 that's looking from that mid-axillary point. And then you probably have your V5 somewhere here in the front looking at it. But overall, they're to the lateral side. So any lateral problems will show up in those leads. Which brings us around to the discussion of continuous leads. And this applies to what we talked about before with our inferiors as well. The idea is if I only have a problem with V6, it's just one lead. It doesn't have as much weight to it. Whereas if I see a similar or the same problem occurring in not only V6, but maybe lead 1 and V5 as well, all 3 of those represent the same portion of the heart or are looking at the same portion of the heart. And so I can say that this problem is large enough that it is affecting multiple leads in the same zone. And that's what really makes a big difference is, being able to say these are continuous leads and then learning which ones are grouped together. Anterior, well, your best anterior leads are going to be V1 through V4. They really do look at that whole front half of the heart. But when it comes to anterior, there's a lot of different pieces to it because circumflex is included, a little bit of the right coronary artery as well. And so there's been some subdivision to help you really give a better name to what types of heart attacks you may had. And you may recognize these names as we talk about them. At the bottom, you've got apical, because remember this is the apex. And if this is the apex, of course, this is the base at this end, because for whatever reason they decided that the heart was an upside down triangle. Anyhow, here at the bottom, what looks at that bottommost portion of the heart? Well, your AVF, this should be the 2 lead, and then your V2 through V4 do a really good job. So if you have trouble in this specific zone, or if you see a problem in these leads, it's more likely a apical infarct or something along that line. Now, if you wind up having significant changes in your V2 through V6, we're going to go ahead and call that anterolateral, because it is a combination between the anterior, so V2 through V4, and you have 5 and 6, well, that's your lateral half. So you have your lateral and your anterior, anterolateral. Now, if you wind up having V1 through V4, and then you add in a little bit of AVL, now you've got anteriobasal, and last but not least, anterioseptal, if you've got your V1 and V2 involved. Because again, those are more focused on that section of the heart. That's the bigger concepts of all this that I wanted to go over. Next stop is going to be 12-lead interpretation of in and of itself. The next big section we're going to spend a lot of time on is the axis here, because it is a complicated topic, but extremely valuable for predicting other problems. And we will pick up there.